Hi, I'm Will Munyon. I'm a third-year resident at Texas A&M Christus Spohn Emergency Medicine Residency. The title of my study is Success Rates for Intubation During Manual and Mechanical Chest Compressions Under Simulated Conditions. I'd like to thank my contributing authors, Dr. Butler, Leeson, Zhu, Torres, and Richmond. I have no financial or non-financial disclosures. By way of introduction, sudden cardiac death accounts for approximately 15% of overall mortality. The American Heart Association emphasizes the importance of high-quality compressions, categorizing factors of appropriate rate, adequate depth, and minimal interruption. A prior mannequin study has identified significant deterioration with the quality of manual compressions over time. For these reasons, mechanical compression devices are becoming a prominent part of both in and out of hospital CPR. In regard to establishing an advanced airway during CPR, current ACLS guidelines leave the decision of if and when to progress to an advanced airway up to the individual practicing provider. A randomized clinical trial in patients with out-of-hospital cardiac arrest showed no significant difference in functional neurologic recovery between those receiving a supraglottic airway compared to those receiving endotracheal intubation. This data adds to the body of evidence that compression should not be halted in order to establish an advanced airway. In regards to intubation during CPR, a study using cadavers and pre-hospital providers using direct laryngoscopy showed 97% success rates without compressions compared to 77% success rates during compressions. However, our literature review showed no prior studies comparing intubation attempts between manual and mechanically driven compressions. The objective of this study was to evaluate ease of intubation, operator confidence, and success rates for intubation between mechanical CPR and manual chest compressions. The study's design was a prospective crossover trial, the setting an academic emergency department simulation center, and the participants 32 emergency department physicians. In regard to protocol, participants performed endotracheal intubation using direct laryngoscopy on an adult mannequin during simulating CPR, with trials of both mechanical and manual compressions. The order in which compressions were delivered was randomized for each participant to minimize the learning curve bias. In terms of statistical methods, paired t-tests were used to control for intraoperator correlation. The primary outcome was time to intubation, comparing mean time to intubation between the two trials. Secondary outcomes included overall success rate of intubation and perceived confidence level as expressed by a 5-point Likert scale. The population consisted of 32 emergency department physicians, 38% were female and 62% male. 78% had 1 to 5 years of experience, 16% had 6 to 10, and 6% had greater than 30 years experience. In regards to primary results, the mean time to intubation during manual compressions was longer compared to that of mechanical compressions, roughly 21 seconds compared to 15 seconds. However, this result was not statistically significant. The secondary results showed that 53% of participants had higher confidence of intubation during mechanical CPR relative to manual CPR, and 47% had no change in reported confidence level. For mechanical compressions, there was a 100% first pass success rate. For manual compressions, there was a 97% first pass success rate. By way of discussion, a prior randomized crossover mannequin study using intern-level providers showed a 75% first pass success rate using direct laryngoscopy during mechanical compressions. Our study showed a 100% first pass success rate using similar settings. As previously mentioned, we found no prior studies comparing intubation between manual and mechanical compressions. Our study showed shorter mean intubation times for mechanical compressions relative to manual, though not statistically significant. Additionally, 53% of participants expressed greater confidence in their intubation attempt during mechanical compressions. These results were contrary to our initial hypothesis, which put forth that intubation would be more difficult during mechanical compressions. One explanation as to why this was not the case looks at the physics behind mechanical compressions. Here, the chest is compressed between the piston and the backboard, which limits the overall movement of the body on the bed. In regard to future studies, video laryngoscopy could be substituted for the direct method used in this study. A prior systematic review showed improved vocal cord visualization in video-guided methods. Additionally, it would be reasonable to see if these results translated to either human or cadaver trials. Limitations of this study included small sample size and the fact that the simulation mannequin does not fully simulate the difficult airway scenarios seen in a real-life resuscitation. In conclusion, under simulated conditions, there were no significant differences in time to intubation by emergency physicians during manual and mechanical compressions. Prior to tube placement confirmation, physicians were less confident of success during manual compressions. Future studies should look at how this translates to human or cadaver subjects, as well as how the use of video-guided laryngoscopy may influence time to intubation and perceived confidence level between manual and mechanical CPR.
Hi, my name is Kate Hughes, and I'm an assistant professor at the University of Arizona. This is my abstract entitled Fear Not, Using Simulation for Medical Malpractice Education. Co-authors on this project are Thomas Carr, Diana Norland, and Patrick Hughes. No authors have any financial disclosures. Medical malpractice payouts across all specialties totaled over $4 billion in 2019. 72% of emergency physicians have been involved in a medical malpractice lawsuit by the age of 55 based on previously published literature. The majority of residencies in emergency medicine do not include adequate education on medical legal risk mitigation and litigation as previously published. The purpose of this study was to implement an innovative interprofessional simulation to target this identified educational gap. This event was set up with a pre and post survey that was anonymous. The pre-survey evaluated baseline medical and legal knowledge, self-rated deposition comfort, and concern regarding malpractice litigation. Participants then were invited to attend an interactive lecture on the basic tenets of medical malpractice and state legal statutes from medical legal experts. They then participated in a simulated deposition, which used resident physician volunteers as defendant physicians and a redacted closed malpractice case. We utilized the rapid cycle deliberate practice debriefing technique, and we stopped and started the simulation throughout the deposition to highlight deposition performance. There were 80 attendees for this event. It included faculty physicians, resident physicians, and advanced practice providers. All of the attendees completed the pre-survey and 66% completed the post-survey. The majority incorrectly answered 80% of our baseline medical legal knowledge questions. And the mean comfort level being deposed was 1.55 and a 1 to 5 Likert, with 1 being extremely uncomfortable and 2 being somewhat uncomfortable prior to the educational event. After participating in the simulation, survey respondents noted an improved comfort being deposed, rating themselves as neutral or somewhat uncomfortable. The mean level of concern or fear regarding malpractice litigation before the simulation was rated between somewhat concerned and moderately concerned, or 3.44 on a 1 to 5 Likert scale. After the educational event and simulation, the level of concern and fear surrounding litigation trended down. However, participants still rated themselves as somewhat concerned. 0 participants self-rated as not at all concerned regarding the litigation when surveyed after the event. Resident physicians were the only respondent category that actually had an increased level of fear or concern for litigation after the event, but this did not achieve statistical significance. The post-survey included questions on qualitative themes for what aspects of the simulation were beneficial and what were areas for improvement. This table summarizes those findings. Participants found the session to be highly educational and very helpful, included relevant information, and was well structured. Our panel of experts, which included a physician expert witness, 2 practicing defense attorneys, and attorneys from our institutional risk management department, was well received by our participants. Areas of improvement included shortening the deposition simulation portion to provide more time for discussion with the panel experts. Respondents also requested that we provide more examples of closed cases or circumstances of litigation versus using just a single case for the deposition. And they requested additional debriefing on performance. So in conclusion, this study highlights the inexperience of not only resident physicians, but also practicing APPs and faculty physicians in deposition. Targeted educational efforts like this lecture and simulated deposition are able to successfully increase participants' comfort with deposition. However, it's important to note that no participant self-rated as extremely comfortable. It's likely that a single intervention is insufficient to prepare resident physicians for a deposition. Participants still rated themselves as somewhat concerned about litigation. Because malpractice litigation represents an area of significant personal time, financial, and emotional burden to physicians, it is infrequently discussed in educational format. It will likely remain a source of anxiety and stress for emergency physicians and may influence future practice patterns. Thank you.
A cost-effective, reusable pericardiocentesis simulation model with an interchangeable model heart and chest wall. Today I will go over the background, disclosures, methods, results, conclusions, and references of our study. I have no disclosures. Cardiac tamponade is a life-threatening condition caused by an increase in intrapericardial pressure due to the accumulation of fluid in the pericardial space. The use of ultrasound for pericardiocentesis is the standard of care. It's a high acuity, low occurrence procedure. There are simulation task trainers that are available for pericardiocentesis training, and is a common method used to help practitioners practice this rarely used skill. The available commercial task trainers can cost thousands to tens of thousands of dollars and can be cost prohibitive to many institutions. A current DIY model exists, which is described on the site EM Daily and in the Journal of Emergency Medicine. It is cost effective, but has limited reusability. We set out to create a model that was similarly cost effective, but also had replaceable parts for greater sustainability. 43 emergency medicine residents from Mount Sinai, Morningside, and West in New York City were involved in the study. The residents were split into either the control group or the intervention group, with each group having 4 to 5 learners per group at a time. The groups had a 10-minute didactic session with the ultrasound director, then 20 minutes with the task trainers, which were led by 2 faculty members. The faculty members assisted the residents in using the models, and they kept track of the number of models, lids, and balloons that were used. The day after the training, a survey was sent to assess if the residents felt like they had enough time with the task trainers. After each group finished their session, the number of models, balloons, and lids were documented. Here are some pictures of the components of our model. First, we have our double balloons, which are meant to simulate the heart and pericardium. The inner balloon is filled with red dye to simulate blood, and the outer balloon was filled with yellow dye to simulate pericardial fluid. Next, we have our gelatin base, which is hollowed out in order to allow one of the balloon heart models to fit in it. The third image shows one of the gelatin bases with a balloon heart model in it, and around the balloon heart model is ultrasound gel in order to fill in the remaining space. Finally, we have one of the complete models with one of the removable lids on top. Here is one of the images of our ultrasound model. Labeled as the pericardium, which is the outer balloon, and also labeled as the pericardial space, which is the space between the inner and outer balloons. Next is an image of a resident using one of our models. The control group had 22 residents in it, and the intervention group had 21 residents. The control group found that each of the EM Daily models were unusable after a single needle insertion. After going through those 3 models, they switched to the novel model in order to let the remaining residents continue training. Of the novel models, 4 novel balloons were used by the end of the training, and 2 lids. 3 of the balloons became unusable after multiple needle insertions into the outer balloon, and 1 balloon was unusable after a resident intentionally punctured the inner balloon and aspirated the red fluid to demonstrate puncturing the pericardium. The intervention group had a total of 3 unusable balloons by the end of the training and 2 unusable lids. 13 residents responded to the post-training survey, with 12 of them responding yes, that they felt they had enough time with the training models. In conclusion, we created a cost-effective and sustainable pericardiocentesis task trainer. Here are our references, and thank you for listening to my talk.
Hello, thank you for your time and welcome to our presentation on the topic of a virtual objective structured clinical examination for transgender and non-binary health education. My name is Kimbia Arno and I'm one of the simulation fellows at NYU Langone. I will be presenting this research along with my co-fellows, Janice Shinkim and Delna John. Our presentation represents our work as well as the work of Aidan Shapiro, Jessica Strauss, Shannon McNamara, and Soma Pathak. We have no financial disclosures to make. Health disparities among the transgender and non-binary patient population are extremely pervasive. It is well documented that trans and non-binary patients suffer a disproportionate amount of poor healthcare outcomes, injury, and violence relative to their cisgender counterparts. Inexperience by cis providers and a lack of education regarding trans and non-binary health can be a barrier to care, and studies suggest transgender patients have reported avoiding ED care because of fear of discrimination. These findings are corroborated by a 2018 ACEP report that suggested that 82.5% of surveyed physicians endorsed receiving no formal training regarding trans and non-binary health, despite 88% of these same physicians similarly reporting having cared for this population of patients. 33% of the ACGME accredited EM residency programs reported some incorporation of LGBT health in their curriculum. However, that data is from 2014, so things may have changed since then. To better prepare our residents to care for this population, we created a virtual objective structured clinical examination, or a virtual OSCE. Our objective was to improve EM residents' knowledge, comfort, and communication skills using gender-affirming vocabulary, including the use of accurate pronouns. We also hoped for residents to provide trauma-informed care, which is the acknowledgement and respect of potential traumas that marginalized populations have experienced in past and present with the healthcare system.
This was a mixed method study using pre- and post-intervention survey conducted at an urban academic emergency medicine department. A transgender faculty member created the cases, and transgender and non-binary individuals were recruited as standardized patients. We started the virtual OSCE with pre-brief to create a psychologically safe learning environment for participants and discuss logistics. The virtual OSCE consisted of 2 scenarios: a transgender male with an ectopic pregnancy, and a non-binary teenager with a suicide attempt. Each scenario consists of a 10-minute encounter, followed by a 10-minute debrief with simulation faculty and standardized patients. Upon completing both scenarios, participants anonymously rated their experience on a Likert scale and provide feedback. Out of 68 eligible participants, 34 residents participate in the virtual OSCE. The pre-survey revealed that 11.8% of residents never had a formal education on transgender patient care during medical school or residency, while 94.1% reported that they had taken care of transgender patients. According to pre-survey, 29.4% of residents shared discomfort with medical management. After the virtual OSCE, this decreased to 8%, which was determined to be statistically significant using a Wilcoxon sign rank test. Prior to the intervention, 11.8% of residents endorsed discomfort with interpersonal communication. After the virtual OSCE, 4% in this case, only 1 resident reported discomfort. Although this finding lacks statistical significance, it still has clinical relevance, especially as all residents found the virtual OSCE session relevant to their clinical practice and would recommend the learning experience to others.
One of the limitations is that this was a single-site educational intervention. Residents' experiences in an urban ED could be quite different from those within other training environments. However, these lessons are relevant to all training environments because transgender and non-binary patients are not limited to only urban environments. 9 residents were lost in the in the post-survey. We hypothesized that this was likely related to time constraints created by the conference and on-call schedule, resulting in residents leaving the Zoom room without completing the surveys. Our study mainly focused on residents' comfort level with medical management and interpersonal communication only. We did not focus on the assessment of medical knowledge surrounding care specific to transgender and non-binary patients. We could also consider the virtual nature of this study as a potential limitation. This took place in the setting of the COVID-19 pandemic, in which learners were used to participating in virtual sessions. Additionally, the virtual environment would allow programs to recruit transgender and non-binary standardized patients, even if they have difficulty recruiting locally. We are continuing to learn more as a field regarding the impact of virtual versus in-person learning. Overall, our virtual ASCII improved resident comfort with both the medical management and interpersonal communication for transgender and non-binary patients. This suggests that a virtual ASCII is a valuable and innovative tool to improve residents' trauma-informed care and communication skills with this population. It also suggests that this might be a useful way to implement a trans health curriculum and improve emergency medicine physicians' competency, even with limited in-person resources. We appreciate the support from these individuals and our simulation center. This is our reference slide. Thank you so much for listening.
Hi everyone, my name is Stephen Bulger. I'm currently a simulation fellow in the Department of Emergency Medicine at Mount Sinai Morningside and Mount Sinai West. And today I'm going to be presenting my project entitled Precipitous Delivery with Shoulder Dystocia and Postpartum Hemorrhage Simulation. So to start off with the background and objectives of this study came from a recent change in our OB-GYN coverage at one of the hospitals in our system. We looked at our residents' comfort with obstetrical emergencies, and we found that our residents have minimal exposure and formal hands-on training related to the independent management of precipitous deliveries, specifically with complications such as shoulder dystocia and postpartum hemorrhage. The objective of this study was then to develop a simulation curriculum that could be used to train our emergency medicine residents in low frequency, high stakes obstetrical emergencies, specifically precipitous deliveries. We hypothesized that simulation would be a powerful tool that could be used to address the learning gaps in the management of obstetrical emergencies among our emergency medicine residents. So for the methods, we ran a simulation during one of our weekly residency conferences. During the conference, we had 35 emergency medicine residents distributed approximately evenly by PGY year between PGY 1, 2, and 3. We created a survey. We kept our survey intentionally brief so that we could maximize the number of responses. And we had our residents fill out the survey within 24 hours of the simulation conference. Many of them filled it out the morning of. We then had them go through the simulation, and then we had them fill out a post survey, which was identical to the pre-survey, within 24 hours of completing the simulation. Many of them filled out the survey at the end of the simulation, at the end of the conference day. So for the pre and post survey questions, we first asked them what PGY year they were, and then we had 3 brief questions. The first question was, describe 3 maneuvers which can be used for shoulder dystocia. The second question was, name 3 history or physical examination findings which can be used to assess for imminent delivery. The third question was, name 2 pharmacologic or non-pharmacologic treatments for postpartum hemorrhage. In terms of the actual simulation, the simulation was run by our simulation division here at Mount Sinai Morningside West. We had several OB-GYN faculty members serve as content experts during the simulation. During the actual simulation, we had the residents go through a case. We allowed the residents to practice all of the maneuvers on the slide for management of shoulder dystocia, and we had the OB-GYN faculty who served as content experts walk the residents through the different maneuvers. We then had the residents also manage the postpartum hemorrhage using pharmacologic and non-pharmacologic measures. And that was also led by our OB-GYN faculty members. After the simulation, we did a formal structured debrief session that was led by our simulation faculty. The debrief was based on a series of questions that were agreed upon ahead of time and allowed the learners to reinforce the concepts that they had practiced in the actual simulation session. So in terms of the results of our study, we looked at all of the data and we scored each response as either correct, incorrect, or if it was blank, we scored it as blank based on our predefined criteria. So for the first question, maneuvers for shoulder dystocia, we found that there was an increase in the number of correct responses looking at the pre compared to post survey. We found a decrease in the number of incorrect and blank responses for that question. For signs of imminent delivery, we similarly found an increase in the number of correct responses, a decrease in the number of incorrect, and also decrease in the number of blank. For the third question, treatments for postpartum hemorrhage, we found an increase in the number of correct, a decrease in the number of blank. For the incorrect responses, they were low pre and post survey, but we found a slightly higher increase in the number of incorrect answers in the post compared to the pre-survey. So looking at all the data we collected together, we found that there was a greater proportion of correct answers for all 3 survey questions. We found that there was a lower proportion of incorrect answers for 2 of the 3 survey questions, and we found a lower proportion of blank answers for all 3 survey questions, and that's comparing the post-survey data to the pre-survey data. So our study demonstrated the usefulness of simulation as a teaching tool for low-frequency, high-stakes obstetrical emergencies. It further suggested that a simulation-based curriculum can inform educators of potential learning deficits and additional areas of focus for future educational models. So I just wanted to acknowledge the people that helped in this study. So I wanted to just thank all the amazing residents we have at Mount Sinai Morningside and West for participating in our study. I'm also wanted to thank our chair, Dr. Lagome, as well. Thank you for listening to my presentation.
Hello and welcome to this lightning oral presentation entitled Resident Physician Stress State Variation in Simulated Common Clinical Stressors. My name is Melissa Joseph and I am an assistant professor at the Yale School of Medicine in the Department of Emergency Medicine, and I am the director for resident simulation at the Yale Center for Medical Simulation. This study was funded by the SAEM Simulation Academy by the SAEM Foundation Simulation Academy grant. I have no other disclosures. Emergency medicine physicians make decisions while handling critical patients, team dynamics, and difficult interactions. Simulation-based education often utilizes these embedded stressors to augment cognitive load and mimic the clinical environment, though it is unclear if differing stressors have differing effects. EM physicians are also prone to burnout, which has been linked to the stressors experienced in the clinical areas and can lead to maladaptive stress as well as effects on patients under their care. This study examines the effects of 3 types of stressors on participant task stress as measured by the SSSQ in a simulated clinical environment. Emergency medicine residents participated in a randomized controlled trial examining the effects of 3 distinct clinical stressors: medical difficulty, equipment failure, and interpersonal conflict within 6 simulated scenarios. The order of the scenarios was randomized, as was the stressor. For example, if the base case was pediatric tamponade and the scenario was randomized to have medical difficulty as the stressor, the script was written in that after the initial primary survey, the patient would become rapidly unresponsive, hypotensive, and require an emergent pericardiocentesis. If this was not performed, the patient would go into PEA arrest. As another example, in the central venous thrombosis scenario, if it was randomized to have an interpersonal challenge stressor, the patient's mom would be dismissive of the team's plan for workup, asking, "Is that really necessary? How much is that going to cost? And you don't even know what you're doing. We are going to leave." We utilized the same trained actress for each of the scenarios to utilize the scripted responses as you see here for each randomized stressor. This slide contains examples of some of the responses. Participants completed the Short Stress State Questionnaire, or SSSQ, before and after each scenario. The SSSQ measures 3 broad factors: task engagement, distress, and worry. Task engagement relates to the task interest and focus. Distress is characterized by negative emotion and perceived lack of control, and worry is a reflection of intrusive, distracting, and self-referent thoughts. 35 EM residents were recruited during their simulation rotation. 1 declined participation, 1 met exclusion criteria, and 3 were familiar with the scenarios. 3 had scheduling conflicts, and 2 were halted halfway secondary to COVID-19 restrictions, with a resultant 25 participants. A one-way ANOVA was performed to test whether the mean state change differed across the stressors for 147 observations. On the task engagement and worry scales, the mean change, which was the difference between the post and pre-test SSSQ, did not differ significantly across the stressors. On the distress scale, the post-test mean was lower for medical difficulty and equipment failure, but was significantly higher for interpersonal conflict, and this reached a P of less than 0.001. The results did not differ when a mixed effects model was run for each dimension to address correlation within subject or by simulation case. In conclusion, our study found that an interpersonal conflict resulted in a statistically significant increase in distress as measured by the SSSQ compared with other common stressors. Further understanding of the different types of stressors and their effects on physician response will help further simulation-based education and, ultimately, work toward mitigation of maladaptive stress and burnout in the clinical setting. Here is a list of the references cited in this presentation, and I thank you and look forward to your questions.
Good afternoon. My name is Jerome Martin. I'd like to thank you all for coming to my presentation at the SEM's 2021 virtual conference. Currently, I'm the Rush Emergency Medicine Simulation Fellow at Rush Medical Center in Chicago, Illinois. I'm pleased to present my project entitled The Novel Cricothyrotomy Assessment Tool for Attending Physicians, a multi-center study of an error avoidance checklist. I currently have no disclosure at this time. I decided to do my presentation today as a bit of a poster presentation. That way we didn't have to do with a lot of clicks as we're doing this new virtual format. So let's get started. This project is actually about the development and implementation of a new error avoidance checklist for the cricothyrotomy procedure. The concept of an error avoidance checklist is actually relatively new to literature. In fact, this project was triggered by a publication done in 2015 by Irene Ma and her colleagues, where they used an error-focused checklist to evaluate incompetence in performing lumbar punctures. The traditional method of procedural training uses checklists with a goal to cause standardization as well as a quality assurance in novice and new learners of a particular procedure. This type of procedural training works well for junior learners and those unfamiliar with particular techniques. However, it falls short when extended out to expert learners. Often, they are perceived as exercise in box ticking and can be very onerous, particularly when dealing with the long and lengthy checklists. Studies have shown that there's less clinical benefit as the experience of the user increases. That produces a bit of a gap with expert learners because the gold standard for high acuity, low occurrence procedures such as a cricothyrotomy is actually deliberate practice and simulation-based mastery learning. However, that's difficult to achieve when it's hard to get those expert learners back into the simulation lab. Thus, we determined rather than focusing on individual steps of a particular procedure, perhaps focusing on specific critical errors can be a more salient way to evaluate expert learners. Particularly in a procedure such as a cricothyrotomy, with multiple different ways to perform the same procedure, that way it honors the variability in their trainings. Through an iterative process, multiple experts came up with a 7-item error avoidance checklist for cricothyrotomies. The checklist was then implemented at 2 different sites by 45 emergency medicine attendings, whom both used the checklist in peer assessments, as well as providing feedback about the individual components of that checklist. We collected data about the performance of the physicians, the feedback about the individual components of the checklist, as well as the relevance and ease of use of the checklist itself. Overall, we found that 4 out of the 5 main errors to be avoided in the checklist had at least an 85% agreement that they were somewhat critical, while only one particular error actually came out to only being 66% agreement that it was somewhat effective or critical, and that was severs the cricoid cartilage. We found that 93% of participants rated the checklist easy to use or very easy to use on a 5-point Likert scale. Taking a look over here at the table number 1, this is actually a depiction of the error avoidance checklist. The 5 main components and errors to be avoided were actually cuts, punctures, or dissects the tissue more than 2 centimeters lateral to the midline of the neck, severs the cricoid cartilage, fails to continuously maintain a localizing device in the airway lumen at any time between cricoid membrane puncture and airway placement, creates a false passage subcutaneously or through a posterior tracheal wall, causes injury to self with a sharp object, causing bloodborne pathogen exposure, and then 2 critical summary or confirmatory statements, which is places endotracheal airway and delivers that initial breath, and completes the procedure in under 120 seconds. The last 2 components here are actually more related to metrics that we wanted to keep, and that was the number of times the procedure was attempted and then the time of final successful attempt in seconds. The second table is actually a depiction of the responses and the feedback that we received about the individual components of the checklist. As you can see, each error is actually a different color, and then all 7 errors are actually represented here. Error number 2, which is the one that we found to be the least agreement that it was critical, as you can see, has a different skew towards the right compared to all the other checklist points that actually had a skew towards the left, meaning that they seem to be more critical. In conclusion, we actually determined that this was a successful project in that it was actually a proof of concept study of the use of this error avoidance checklist. We found that participants overwhelmingly agreed that the tool was reasonable to evaluate cricothyrotomy performance in attending EM physicians. We have a lot of future goals for this data and this project. Some future goals and research that we can do based off of this would be evaluating the innovator reliability of the actual checklist itself, validating the tool, which would also require us to then evaluate the tool with the use of multiple different levels of training and see how novice trainees compare to junior compared to expert trainees utilizing this checklist.
Hello, SAEM. Thanks for inviting us to participate in the lightning round. My name is Eric Roseman.
And my name is Duo Xu.
We are together simulation fellows at Maimonides Medical Center in Brooklyn. In addition, we are both former Kings County graduates. We work together on this project at Maimonides and are hoping to tag team this presentation for you today.
Thanks, Eric. Let me start first by giving some quick background information on Maimonides. The Maimonides Hospital Emergency Room is located in Borough Park, Brooklyn. It averages about 120,000 visits per year, of which about 85,000 are adults and 35,000 are pediatric patients. The emergency department also houses a 3-year emergency medicine residency and graduates about 15 to 20 residents per year. At any given time, approximately 70 full-time attendings and 8 to 10 fellows working in this institution.
Before Duo gets into our methods and results, let me quickly tell you about why we looked at procedural assessments with attending physicians. Many proponents of simulation-based medical education subscribe to the notion of deliberate practice, which was first formalized in the early 90s by psychologist Kay Erikson. The model suggests that expert performance can only be achieved and maintained through escalating levels of instruction, practice, and directed feedback, which develops over the course of one's career. Deliberate practice has become a cornerstone of resident sim curricula at institutions across the country. Task trainers and procedural assessments, for example, are routinely used in resident education. However, their use with attending level learners is much less common. Erickson proposed that after the end of organized medical training, continued access to conditions for deliberate practice, as well as feedback on daily medical practice, might allow doctors to keep improving their performance to achieve even higher levels. Despite the importance that Erickson placed on ongoing deliberate practice, this is not something we routinely see with attending faculty. Various barriers to entry of such higher level learners have been proposed. Some of these barriers include general assessment apprehension, poor faculty engagement, lack of realism, lack of opportunity, and lack of administrative support. Here at Maimonides, we believe in continued deliberate practice as an important part of faculty development, and we suspect that perceived barriers to entry may not be as prevalent as initially proposed. The objective of this study was to evaluate faculty perceptions of mandatory simulation-based procedural assessment.
So let me talk about what we actually did. Our study specifically looked into procedure assessment sessions during a new attending onboarding process. These sessions were initially designed to ensure patient safety, but they also play a role in initiating ongoing deliberate practice for new attendings. Over the course of 5 years, 52 new EM attendings, as well as fellows, participate in the sessions. Each of these sessions were composed of a didactic portion, followed by a practice portion, and ended with assessment portion of 3 common ED procedures: central venous catheter placement, video laryngoscopy, and chest thoracostomy. At the end of each session, participants were given a post-survey of which they filled out on a voluntary basis. Our surveys have an adequate response rate of over 70% across all 3 procedures. From these responses, we found that greater than 90% of participants found the sessions enjoyable. Meanwhile, over 85% of participants found the sessions helpful. And lastly, over 85% of participants found the sessions realistic. In summary, our study demonstrates that the historical barriers to simulation-based assessments were not prevalent in our population, and a great majority of the participants actually found the sessions enjoyable, helpful, and realistic. Based on our study results, we recommend that more institutions to incorporate formal simulation-based assessments into their continuing professional development curriculum. This should encourage ongoing deliberate practice at all levels of learning. Thank you guys for your time listening to us. We now would like to open the floor to any questions you guys might have.